dear friends and colleagues, and I'm really grateful to the organizers of the ESD, and particularly my friend Professor Papasaurus, for this very kind invitation. My name is Hammad. I'm Professor of Urology at ATHER University in Karachi, and I've been associated with ESD since its inception by our dear late friend Mr. Bohos. So I've been asked to talk about renal damage in the minimally invasive options of treatment available to the modern day urologist. We have seen a significant shift, a paradigm shift from open stone surgery to minimally invasive surgery, and perhaps one of the most minimally invasive surgical option is lithotripsy. Introduced in the early mid-80s, it has really become the cornerstone of management of most stones. However, we have learned over the years to select our patients appropriately. It's non-invasive, it's targeted with real-time monitoring. Very infrequently we need anesthesia. However, it's important that we need to select our patients appropriately with respect to not only stone size, also its location and density and various patient-related factors. Lithotripsy is not without complications. Hematuria, skin bruising, and development of Steinstrasse are some of the common complications of lithotripsy. Now, the shockwave lithotripsy-related kidney injury is typically either due to mechanical trauma, cavitation, and ischemia perfusion injury. Now, the same principle which is responsible for stone fragmentation, that is creation of a cavitation bubble, causes damage or potential to cause damage to the delicate epithelium of the collecting system. The direct shear, stress, and compression factor secondary to lithotripsy is another cause for ischemia of renal injury. However, ischemia reperfusion injury is a paradoxical tissue damage caused when the blood supply returns to a tissue after a period of oxygen deprivation. The sudden influx of oxygen triggers oxidative stress, inflammation, and cellular calcium overload, resulting in severe damage. And up to 50% of the final injury is caused by reperfusion injury. Renal tubular damage from lithotripsy is also documented. Now, the acute effect of lithotripsy is seen immediately, and it is typically vascular or direct parenchymal injury. It results in nephronal and tubular injury, particularly to the basement membrane. The renal hemorrhage and hematoma is most common. It could be intraparenchymal, subcapsular, or perirenal. If you look at the incidence or prevalence of hematoma or hemorrhagic complication, and if you do a CT scan immediately after treatment, you will find that 1/4 of the patient would have some form of a hematoma. Now, where clinically significant is only seen about 1% of the population. The renal contusion and edema, which is from leakage of urine and blood into the interstitial space with the resultant compression effect, is also one of the ways of causing renal injury. Transient decrease in the renal function is an outcome of these factors. The acute hemorrhage, fortunately, is very infrequently seen in 1 to 4% of the patient. The increased tissue damage risk is if you use shock waves more than 1,500 to 2,000, if you use high voltage or high energy, if you use fast rate of shock wave delivery, and if the patient has certain underlying conditions including hypertension, diabetes, and coagulopathies. The slow versus fast rate is documented many decades back, that not only it improves stone fragmentation, but it can also potentially save damage to the kidney. So the potential chronic and long-term effects of lithotripsy, fortunately, are not very frequently seen. Most of these acute events resolve within weeks, and there is a less potential for long-term consequences, but they can still happen. The permanent loss of renal volume, which occurs from severe acute damage, which subsequent scarring and fibrosis. The development of new onset hypertension, which again is from renal scarring and persistent subcapsular hematoma with compression effect. Lithotripsy can also increase the stone recurrence rate, and if there is injury to the surrounding organs like pancreas, diabetes be a consequence. What are the risk factors and how can we prevent them? Well, these risk factors are either related to the patient factor, with increased age, poorly controlled hypertension, diabetes, and pre-existing renal injury, renal damage, with various treatment-relating parameters, including high energy levels, greater number of shock waves, and fast rate of delivery. So protective strategies to do power ramping. Perhaps one of the most frequently performed endourological intervention for stone disease in the 21st century is flexible ureteroscopy. The mechanism for flexible ureteroscopy related renal damage is due to elevated intrarenal pressure. We know that the typical resting pressures are between 0 to 15. However, during flexible ureteroscopy, the pressures can go up to 40 and even at times 100 centimeters of water. And this has a significant impact on pilorenal and pilovenous backflow, with infection and sepsis. The bacterial translocation from the stone and urine into the blood can result in sepsis and sepsis-related acute kidney injury. It can be demonstrated by elevated NGAL, KIM1, and NAG values in that phase. The mechanism of renal damage during flexible ureteroscopy is also due to renal ischemia and hyperperfusion, and this typically occurs because the increased intrarenal interstitial pressure and swelling can compress the intrarenal vessels, and outer medulla is the most frequently affected. The direct mechanical and laser injuries are also documented, which can result in bleeding and subsequent focal necrosis, development of cortical scarring, of collecting system narrowing. The delay effects are inflammatory, which includes high pressure and heat with the formation of subepithelial nests, pericalyceal and focal scarring. All this can result in long-term damage to the kidney. So flexible ureteroscopy related AKI is seen in about 10 to 15% of patients. Fortunately, majority of these are reversible. And the reasons for development is if you're treating larger stones, the operating time is long, there is persistent high intrarenal pressure, and if the patient has pre-existing diabetes and urinary tract infections. The prolonged operating time and high stone burden is something that can be avoided in order to decrease the chances of ureteroscopy-related injury. If the patient is not pre-stented, lack of which can result in ureteral access-related injuries to the ureters with ischemia and stricture formation, which can potentially lead to long-term renal functional impairment. The infection and diabetes are pre-existing factors. The third and the most perhaps invasive of the endourological intervention that we as urologists use is percutaneous nephrolithotomy. Percutaneous nephrolithotomy related mechanical trauma is the most frequent cause of renal injury. The vascular insult, which is upon development of the access into the kidney, which results from either vasoconstriction, which is more frequent, which is an immediate response to the access, or direct vascular injuries can both result in short-term or long-term damage. High intrarenal pressure are relatively less frequent in percutaneous surgeries due to adequate drainage. However, it can happen, and the perfusion leakage will occur if the pressure go above 30. Interstitial edema and inflammatory cell infiltration would be consequence, and it can result in long-term damage as well. The infection and sepsis, which is often due to the fragmentation of infective stones, release of antitoxin and bacteria, with subsequent the systemic inflammatory response syndrome, along with sepsis, can cause AKI. The potential consequences are AKI, renal atrophy, renal scarring with damage to the collecting system, and formation of permanent scar tissue and strictures. The risk factor for PCNL related damage includes multiple access, and we know now that it is better to have access from below as well as from above for complex stones. Long operative time, again, it is better to stage this surgery rather than performing 3-4 hour long surgeries for complex stones. Pre-existing conditions like solitary kidney, pre-existing CKD, and large staghorn stones can all increase the chances of PCNL related renal damage. The safety in special situations, for example, patients who have got bleeding disorder, we know that ESWL is a contraindication, so is PCNL. However, ureteroscopy is safer in that modality. Patients who have got CKD, ureteroscopies and PCNL even are safer compared to lithotripsy. Patients who have single kidney, if they are undergoing ESWL, ancillary stents are mandatory, and for ureteroscopy and PCNL, they can be relatively safely performed. So, in summary, ladies and gentlemen, the introduction of minimally invasive surgical options to the endourologist, including ESWL, ureteroscopy, and PCNL, have significantly decreased the chances of long-term damage. However, we need to be careful that we do not exceed the time limits and cause injury to the kidney. All MIS modalities can potentially harm the damage, which is frequently, unfortunately, often short-term, but it could be a long-term consequence as well with subsequent development of kidney dysfunction. Patient and stone volume should dictate the choice of procedure, and it is important that the patients are counseled before a surgical procedure. Stage procedures are performed for larger and more complex stones. Thank you very much for your attention.